A warm welcome to all our participants for joining us live. And my name is Shruti. I lead Mission Cure's patient education program. And I'm here today with my colleagues, Megan Golden, Dr. Lola Rahib, Daniel Morgan, Isabel Aguirre, and Olivia Zaiden. Today's Mission Cure webinar is on new pancreatitis treatments in development, created for our pancreatitis patients and their families. We thank you for being here today and for your support. I also welcome our community of clinicians and researchers joining us, and we have over 280 people registered for the webinar. Our webinar agenda is outlined on this slide. Today, you'll hear from Mission Cure's very own, our CEO and our research portfolio manager. I'm excited to have Dr. Gittes and Dr. Machicado, our guest speakers, here to discuss their respective treatment options in development. We are committed to offering our pancreatitis community the latest insights and actionable information. This webinar is part of our patient education program supported by AbbVie. Thank you. Before we start, please know that this webinar will be recorded and posted on the Mission Cure website. You have joined in listen-only mode, meaning we can't hear you. If you have any questions, there's a Q&A option on your toolbar at the bottom of your screen. Please type them into the box. At the end of the webinar, our speakers will answer them. We understand that receiving a diagnosis of recurrent acute or chronic pancreatitis, along with the message, there's no treatment available, can be just as challenging as dealing with the disease itself. This webinar aims to offer insights into the latest treatment options being developed for pancreatitis patients. We also wanted to take this opportunity to share Mission Cure's approach and progress and offer an overview of the drug development pipeline. We want to show our community that hope is backed by real action. Megan Golden, our CEO, will talk to you about what we are doing to find a cure. Megan, the floor is yours.
Thank you, Shruti, and welcome, everybody. Most of you know how Mission Cure started. Linda Martin, my brother Eric, and I co-founded it in 2017. Both Eric, who I think is here in our audience, and Linda's daughter Amy had been diagnosed with chronic pancreatitis after many years of pain and misdiagnosis. And doctors said there was no treatment and that the only thing they could do was try to manage or palliate the pain. So Mission Cure is different from the typical disease foundation. When we launched 6 years ago, one of our first steps was to survey patients to see what outcomes are most important to them. Number one was pain, not surprisingly, but there were others as well. We then developed, with help from leading pancreas experts, a strategy to improve those outcomes by developing therapies. Our strategy is guided both by the community's needs, but also by the science behind potential treatments. And we're pursuing several different approaches to stopping the disease instead of picking just one, which is often referred to as taking multiple shots on goal. So next slide, I want to explain what we're doing to find a cure as background to today's presentation. First, we track research on the pancreas and cutting-edge new technologies like stem cell therapy so that we can find approaches that could work. Second, we meet with researchers, drug companies, biotech companies, and others and explain what pancreatitis patients' lives are like, how badly treatments are needed, and we also make the case that developing treatments is feasible and that it would be a good investment. Third, for those that agree to pursue treatments, we help them by reviewing their research designs, connecting them with experts and clinical trial sites, and recruiting patients to participate in clinical trials. We also help them find funding. In the future, if we can raise enough funding, we may also fund clinical trials ourselves. And then fourth, we pull all of the possible treatments we're pursuing into what we call our portfolio of potential therapies. So we're constantly adding to this portfolio and prioritizing the patients, the projects in the portfolio based on what's most scientifically promising and also feasible. And then the priority projects go onto our development pipeline on our website and receive dedicated attention from our scientists. Which brings me, next slide, to my colleague Daniel Morgan, who manages our therapy development portfolio. Daniel has his master's in biomedical engineering from Cornell and a personal connection to pancreatic disease. He will show you where to find this pipeline on our website and give you some highlights. Daniel?
Hi, everyone. My name is Daniel Morgan, and I am a scientist at Mission Cure. My role here includes managing the portfolio of potential therapeutics, and today I will give an overview of Mission Cure's drug development pipeline. Next slide, please. So this is where you can find our pipeline on our website, under the Clinical Trials and Strategy section. The red arrows are pointing to it. Slide, please. First, a quick explanation of what you're looking at. Similar to us, pharmaceutical companies developing therapeutics have a pipeline on their website that lets you know how far along a product is in its research. Starting from the left, you can see the target column. This column lets you know what biological process the therapy is trying to fix to treat the disease. When a target has been identified, the next step is to find a therapy, drug, or procedure best suited to address the target. This is represented in the therapeutic discovery column. After this, preclinical research is conducted on animals like mice or on human cells in the lab to determine safety and effectiveness. Then comes the exciting part, where the drug can be tested in humans. I'm going to go ahead and highlight a few potential pancreatitis treatments that have made it to clinical trials where they are testing them in real patients. I'll start with pirfenidone. You can find pirfenidone on the 6th row of our pipeline. Pirfenidone is an oral medication already approved by the FDA for idiopathic pulmonary fibrosis, so we know a lot about its safety. Dr. Dudeja and his team at the University of Alabama, Birmingham have shown in their lab that pirfenidone decreases inflammation and the immune system's response in animal models. They'll soon start a clinical trial to test whether it decreases the severity and number of pancreatitis flares in patients with recurrent acute pancreatitis. On the third line of our pipeline is a stem cell therapy. The target here is TRPV1, a gene associated with pain receptors. This is being led by stem cell expert Dr. Hongjun Wang from the Medical University of South Carolina. This treatment has made it to the clinical trial stage after showing it was effective in the lab and also for other diseases. To accomplish this, the doctors take stem cells from your bone marrow, grow them until they have enough, and then inject the stem cells back into your body. This trial is just starting to accept patients, and if you have questions or concerns, Chloe would be happy to speak to you over the phone or by email. A third therapeutic in development is proglomide. This can be found on the 4th line of our pipeline, and research is being conducted by Dr. Jill Smith and her team out of Georgetown University in Washington, D.C. Proglomide targets molecules called the cholecystokinin receptors. In the lab, proglomide reduced fibrosis and inflammation in mice with chronic pancreatitis. It has completed its phase 1 clinical trial and is looking to move into a second phase trial to gain further information on the effectiveness of this treatment. There are lots of other treatments in development, and we are working to move the most promising ones forward. I encourage everyone to reach out with questions to me or to the contacts listed on the slide here. Thank you.
Thank you, Daniel. So I get to introduce our first guest panelist, Dr. George Gittes. Dr. Gittes is a distinguished surgeon scientist at the University of Pittsburgh's Children's Hospital of Pittsburgh, and he's a professor of pediatric surgery and pediatrics. His career spans over 30 years, and his research focuses on seeking cures for diabetes and non-surgical solutions for chronic pancreatitis. So some background, I heard Dr. Gittes present at the National Institutes of Health meeting in Pittsburgh last summer. And he presented on his discovery of this chemical pancreatectomy procedure. The work was so interesting and compelling that we wanted him to share it with our community. This is a really sciencey presentation, more so than our usual webinar presentation. And it's basically the one that he presented to the researchers. There's a lot more work to do before treatment's approved. This is still pretty early stage. And it wouldn't be a first-line treatment, but we really wanted to highlight it because his approach is innovative, and so that you can see what the early stages of therapy development are like. So now Dr. Gittes will tell you about chemical pancreatectomy. Over to you, Dr. Gittes.
Okay, thanks, Megan. We can go to the next slide. This is something that we've sort of stumbled onto, and I had not been a pancreatitis researcher. I was a diabetes researcher. But I want to give a little background on the pancreas anatomy because it's relevant to this talk. So the pancreas has these two components. One is the exocrine tissue, which makes up 98% of it, which is shown there. Those little, Shruti, I don't know if you can show the exocrine tissue there. No, okay. Arrow's not working. Okay, that's too bad. Anyway, so most of that, and that makes all those enzymes that cause the problem in pancreatitis and eat up the pancreas and cause pain. But then there's this other part that's only 2%, but super important, which is all these hormone cells that form a ball called an islet, like a small island. And there's made up of these very important cells, beta cells that make insulin, alpha cells, glucagon, which counteracts. And those are very delicate, and we want to preserve those. Next slide. So anyway, so chronic pancreatitis is strongly associated with a secondary disease that it causes, which is a form of diabetes called 3C. But 3C is really nasty because not only do you not have insulin, so they have to give themselves insulin, but if they overdose a little bit, it goes low, and they don't have those other hormones to kick in and bring it back up again. So it's what's called a very brittle form. So about 150,000, maybe 250,000 people in the US have chronic pancreatitis. Cystic fibrosis is also associated with this diabetes. About half of them have that, and the longer they live with their diseases, the more likely they are to have it. So the pancreatitis inflammation obviously causes pain. That's the biggest problem, but also causes this diabetes that's so bad. And they also have a 13-fold risk of pancreatic cancer. And for cystic fibrosis, that's a lung disease, but this diabetes is the #1 problem outside of the lung. So it's pretty significant. Next slide. So on the left is showing all the different causes of diabetes. So type 3C, this one I'm talking about, is only about 9%. But then if you look on the right at what causes that 3C diabetes, but there's the cursor, yay. The vast majority of the type 3C diabetes is caused by chronic pancreatitis, and there's cystic fibrosis up there too. Okay, next slide. All right, so we touched a little bit on it. What are the options for treatment? They're not very good. Pain medicine, typically narcotics, and a lot of people get addicted. And then there's these different surgeries that involve either drainage, where if there's fluid that builds up, or if part of the pancreas is bad and part is good, you can take out the bad part. But those are pretty big procedures that often are done either through a big cut in the abdomen called a laparotomy, or through the mouth, better, but more difficult. Now, some patients are designated as candidates for this very different kind of approach, which is to go in with big surgery, take out the entire pancreas, and then grind it up quickly, and then find those islets and put them back into the liver. Here in Pittsburgh, we do about one a month. The problem is it's a huge surgery, and also they usually go on to develop diabetes anyway, because the islets don't work very well in the liver. Next slide. All right, so this chemical pancreatectomy is something we made it up because it didn't exist before. And I said I wasn't a pancreatitis person, but we were studying infusions into the pancreas. So the pancreas makes these juices, these enzymes that digest food. Well, so there has to be an opening into the intestine for it to get there. And we take advantage of that by going upstream through it into the pancreas. And we initially used it to do viruses for gene therapy and for kind of studying how the insulin cells form. But then let's go to the next slide. But then, and here's a picture of the infusion system. So you can see there's a little catheter that's going into the pancreas, and you can infuse it. On the right side, there's a yellow arrow pointing to the catheter in the pancreas. We infuse through that. But then one of the guys in the lab knew about this infusion system for virus, but he wanted to use get a high concentration of a drug called tamoxifen. It's a breast cancer drug. Tamoxifen into the pancreas. So he says, "Hey, why don't I use this infusion system? It's great. There's only one problem. The way you give it, it has to be dissolved in 100% ethanol." And he comes and tells me he did this. I'm like, "What are you talking about? They're just going to die." He goes, "No, they're fine. They're running around the cage." I'm like, really? So I go and look. I go into the where the animals are when I sacrifice one of these mice and open up to look at the pancreas. Next slide. And on the right is a normal pancreas, the upper right part of it, where it's kind of pink. But then on the far left is what I saw, and the pancreas was gone, except all of those islets are perfectly preserved. The white arrows are pointing to all of them. And in the middle there, that's showing that the islets are kind of bluish, and then this is under the microscope. The surrounding tissue is all there's no more of the exocrine tissue is all gone. Next slide. So it turns out it's still 100% ethanol is still kind of toxic. So we said, well, maybe there's other chemicals we can try. So we tried a bunch of chemicals, and the one that was actually better and much less toxic was acetic acid. Well, vinegar is acetic acid, but table vinegar is 4 to 5%. We only needed 1%. So it was very benign and worked great. So we kind of took off with that. Next slide. Oh, wait, no, go back. I forgot to say. So this is cool. So if you look at the pancreas picture on the right, you remember it was pink in the picture, the one before, it's now white. And it's been, because it's been cooked by the acid. So you can cook food with either heat or acid. If you ever had ceviche, that's cooked with acid. Anyway, so this is what's happened. So it's basically pickled, literally pickled the pancreas, and this is only after 48 hours. So nothing, the whole thing hasn't finished. Next slide. And here you can see when we look at the staining for the different hormones, they're all, so on the far left upper is the green is those enzymes, but that's a normal mouse. That's all gone by 2 days. But all the hormone cells are perfectly preserved, and they stay that way for 6 months, and there's no regeneration of the bad tissue. So we're very happy with that. Next slide. This is what the pancreas looks like after a week. So instead of being that white cooked thing, now it's clear, and you see again all these islets are perfectly preserved. And then on the right, you see that this is fatty replacement. It's called, very common. We see it in humans. It's harmless. Next slide. All right, so there is some inflammation. So in the upper left panel, you can see there's a lot of dark cells. There's islets that are kind of more reddish purple, and there's some blood vessels that are red, but there's these dark cells. Those are inflammation cells from the immune system. And there's a lot of them kind of cleaning up the mess, cleaning up all that cooked pancreas. And that's at 2 weeks. By 4 weeks, there's still a little. By 8 weeks, there's none. And by 6 months, there's still none. Okay, next slide. All right, very important. So the hormone cells need to have a blood flow right next to them. And the small little blood vessels are called capillaries, and they're in red. And the hormone cells are in green. You can see the normals have lots of them, but then they stay there. They're still there. And by 6 months, you can see they're all still there. It's fine. But on the next slide, you'll see when we do a very high magnification electron microscopy, on the left, I'm trying to show where's the connection between the little capillary, the little blood vessel, which is on the right, and you can see there's a big blob of gray. That's a red blood cell. And then on the left, there's all these things with these little balls inside. That's insulin granules. So, but you can see the lining of that blood vessel has all these little holes in it. I wish I could point to it, because it's like these little beads. It's like a string of beads, but in between each bead is a little hole. And that's really important, because that means it's really easy for the blood sugar, glucose, to get out of the blood into the cell, so the cell can understand what it needs to do. And then if it needs to give insulin, boom, it goes right back in. So it's a very fast connection. And to show you that on the far right, then again, with the magnified view of the middle, they're still there at 6 months. You can still see the little string of beads. So that was very important. And that's why when you give islets into the liver or something like that, that's why they don't work well, because those things are all gone. So it's a very nice finding here for us. Next. Okay, the other real surprise was So on the left, you see these three graphs. One is blue, is a mouse that's never been touched. And then red is one where they just got a salt solution infusion. They didn't get the acetic acid. And then the green is acetic acid. So this is called a glucose tolerance test. And when you give the sugar to these mice, their body needs to respond by making insulin. Well, guess what? When you do acetic acid, they respond better. So the lower these curves are, the better they're responding. So these are actually better than a normal mouse. We call it sort of supranormal, which was a shocker. And we are studying this very aggressively to understand why that is, because it may have very important ramifications for, for diabetes treatment. Next slide. Okay, so what about chronic pancreatitis? These are kind of normal mice. So it turns out, so here's on the left, we give a drug to these mice over weeks, and this pancreas on the left looks horrible. The islets are semi-okay, but the rest of it is just a mess. Whereas if we intervene, and that's severe chronic pancreatitis, if we intervene with this acetic acid solution infusion, halfway through the course of the drug, they're absolutely fine. And you can see the islets are there in the kind of the pink balls. And there's that fatty replacement thing again, which is all the little clear spots. So that was very encouraging. Next slide. So one of the ways we measure pancreatitis is through these enzymes in the blood, amylase and lipase. You can see the tallest bar there in both graphs is when they have regular chronic pancreatitis. But then to the right of those two tall bars is when we give you acetic acid, and you can see that it's back to these other normal ones on the left. Next slide. And then, of course, the big question is pain. So we have very sophisticated ways of looking at pain in mice. And again, the high bar, these are both sort of measures of pain. The high bar is when they have regular chronic pancreatitis, and to the right of it is when we give the infusion that takes away all their pain. So next slide. So that's great, except those are mice, and you can't just go from mouse to human. So we said, okay, let's see if it works in a monkey. And I must say, as a surgeon, the consistency of the mouse pancreas is nothing like a human. It's completely different. Whereas the monkey is almost identical. It essentially is identical. And there is no model of chronic pancreatitis in monkeys, but we want to at least say, does this system work in a monkey such that we could then move to humans and do infusions of chronic pancreatitis humans? All right, so next slide. Yeah, okay, so this is so that you can see there's a little fine line. That's that catheter that's carrying the acetic acid into the pancreas. We haven't started the infusion yet. This is an X-ray. We have to do a surgery on the monkeys. We won't have to do surgery on the people. They'll go through the mouth with a scope. So no cuts. And then you can start the video. So now you can see we're injecting the acid with dye. Animals breathing, heart beating. And you can see how this dark dye is starting to fill up the whole pancreas. There it is. And that was very important to us because it means that the same system that we use in the mice could be used in the monkeys. And it's getting into the main pancreas and then filling up all the little fine branches and filling it up. And the next slide will show you how it, when we then, after this infusion, I then go to the pancreas and look at it. You go to the next slide. Yeah, there's some blue dye in the solution, so you can see it's full. It's all full. It's full of this. This is all acetic acid with blue dye in it. So this quite. And again, remember this would be through a scope called the ERCP in a human, not a surgery. Oh, I forgot to mention in the monkeys in humans we will use 2%. It just worked better for some reason. We're not really clear why. Next slide. All right, so here's the result 8 weeks after that infusion. It's the same thing as in the mouse. You've got the pancreas is gone. It's just the white dotted line outlines like this fatty tissue. And then you can see with the magnified view on the left, these are all these nice islets that are just clustered together and very happy. Next slide. And then everybody asks about, do they get pancreatitis from this infusion? And the answer is not really. There's a few days where their amylase and lipase are elevated, but by 3 to 4 days, it's back down to normal. And they don't look sick. They don't look sick at all, even if they've had a big surgery. And then on the right is that same phenomenon, that crazy phenomenon where they have the way they control the blood sugar is so much better. That's the red is the infused ones. So much better. Which could be really cool in a patient with chronic pancreatitis, because it means that even if they have diabetes or if they have problems, it might make them better. So we'll see. Next slide. All right, so that's just a summary here. So, a dilute 2% acetic acid solution gets rid of all the bad pancreas. Endocrine function is perfectly maintained, actually is better than normal. And certainly in the mouse, it suggests that the pain is resolved, which we are excited about. The nerves are intact, so they don't have any problems with the innervation of the pancreas. So next slide. So future plans. So we are poised now. I think in middle of August, we're going to go and do large animal toxicology studies, which is what the FDA requires. 2% acetic acid is not approved by the FDA. So we have to get their approval. And that requires this toxicology thing. I'm sure it'll be fine, but because we've done this in a million monkeys. But we have to do it. So we're going to actually do that in August. It takes about a month. We'll do the infusions, and then FDA wants 30 days worth of information. And it's in terms of who to start with. We decided that the perfect patients to start with are the ones that have this chronic pancreatitis, and they've been designated as candidates for that total pancreatectomy with islet auto transplant. Like I said, we get about one a month here in Pittsburgh. So obviously, if they're selected, they're relatively healthy. We're going to go up to them and say, hey, how about this instead? Instead of this giant operation and islets going into your liver that probably won't work for very long or very well, how about this? So we're optimistic that we're going to have some success. I've already received probably 150 emails from people that have read some of the literature that we published and say, when can I be in your trial? So I don't think we'll have any problem recruiting people. But I think with the FDA, you got to make sure it's the right population to start with, because once it starts working, it's going to open the floodgates. And this is the other applications. I mentioned cystic fibrosis, but also pancreas transplant for type 1 diabetes. Pretty interesting. Could it work in acute pancreatitis? Sure. And then we've been studying all these already. So cancer prevention or palliation for certain patients at high risk or that have pain and other symptoms from cancer but don't want to undergo a big operation. So next slide. So this is my team. It's a great group, a lot of different skill sets, and this is in our research tower with a backdrop of Pittsburgh there in the background. And I thank you all for your attention. I guess we'll have some questions at the end, I understand.
Yes, absolutely. Thank you so much, Dr. Gittes, for giving us a sneak peek into the treatment's discovery process and the preclinical trial stages. This promising new science and your team's dedication bring hope for more effective treatment for chronic pancreatitis as it moves towards human clinical trials. We would love to have you back to discuss the findings of the human pilot study and trial recruitment in the coming months. We wish you and your team the very best. And a quick note to our audience, keep those questions coming and we'll get to them in the Q&A session. Now, let me introduce our second panelist, Dr. Jorge Machicado, Assistant Professor of Medicine at the University of Michigan's Division of Gastroenterology and Hepatology. Dr. Machicado is a practicing gastroenterologist trained in advanced endoscopic procedures with over 15 years of patient care experience. He's leading the Transcutaneous Electrical Acustimulation study and will talk to us about whether this type of electrical stimulation can help relieve pancreatitis pain. This study will start recruiting for the stage 2 clinical trial, and participants can be based anywhere in the US. Dr. Machicado, over to you.
Thank you so much, Shruti, and thank you, Mission Cure, for the opportunity to share this research with our patients and advances in the treatment of chronic pancreatitis. So, as all of you are aware, many patients with chronic pancreatitis, approximately 90% of our patients experience pain throughout the disease course. This is usually severe, of long durations, affects the quality of life of our patients, and can take patients even to disability after trying different medications. So this is a problem that definitely we need to try to find ways to tackle in chronic pancreatitis. What we're going to talk today, I'm going to explain a little bit about the different pain mechanisms that can lead to pain in chronic pancreatitis. We'll review some current treatment options. We'll discuss about the challenges to find a right therapy for our patients. And then we're going to dive into the role of neuromodulation for treatment of pain in chronic pancreatitis. And we're going to review what is this transcutaneous electrical acustimulation that we're going to call TEA, device for the rest of the presentation. Next slide, please. Abdominal pain in chronic pancreatitis can be divided as being due to peripheral pain, what we call plumbing problems too. And this can be related to problems such as inflammation, or when the pancreatic duct gets obstructed, or with fluid collections around the pancreas, sometimes also due to extrapancreatic causes such as peptic ulcers or other vascular abnormalities. However, the pain in pancreatitis can also be related to central pain, or what we call wiring problems. This can be due to neuropathy or lack of inhibition of pain in the central nervous system. In this situation, sometimes the pain may become independent of the original drive in the pancreas, and the brain loses the ability to inhibit sometimes the sensation that the patient is experiencing. Next. So this is a list of the different treatment approaches that we have for treating pain in chronic pancreatitis. In the left, in blue, you can see the different therapies that are available for peripheral directed therapies. These include modifying risk factors such as tobacco or alcohol, decreasing pancreatic activity, providing analgesic therapy such as ibuprofen, naproxen, Tylenol. We know many times this doesn't work, and many of our patients require opioids throughout the disease course. We also perform invasive procedures such as ERCPs, what Dr. Gittes was describing before, in which we can inject that into the pancreatic duct, remove stones, put stents into strictures, or sometimes patients require operations as well to correct problems that may improve the drainage of the pancreas. However, despite all these interventions, many patients continue experiencing pain, and this can be explained because there's central mechanisms, wiring problems that can be causing pain. In these situations, there has been medications or interventions that can affect the nerves or the mood, such as antidepressants, gabapentin, behavioral therapy, that sometimes have demonstrated to help with pain in our patients with chronic pancreatitis. However, despite this, patients can continue with pain, and there has been a lot of research that has occurred in the past and that is going on to evaluate the role of neuromodulation in trying to help pain in patients with chronic pancreatitis. And this is where we're going to focus the second part of the talk. Next slide, please. So the goal is obviously to try to differentiate between peripheral and central pain, so we can assign the right therapy for the right patient, and in that way being able to improve their pain without requiring to add different medications or treatments that may actually harm and not necessarily help with their pain. Despite our efforts on this, still our current practice includes doing images to find that the duct is obstructed or not, sometimes perform ERCPs or surgeries, but despite of this, 50% of patients remain with pain after 10 years of experiencing pancreatitis, and many are in fact in opioid medications. So this takes us to trying to understand novel therapies such as neuromodulation for treating pain in chronic pancreatitis. Neuromodulation is defined as a way to adjust nerve activity to ease pain or neurological issues, targeting specific areas of the body, especially nerves or areas located close to the nerves, and by this way relieving different symptoms. This can target symptoms such as pain, nausea, vomiting. And different studies have shown that, for example, a specific type of neuromodulation, what many of us are familiar with, which is Chinese traditional acupuncture, can improve chronic pain, osteoarthritis, and migraines. But not only this, it can also improve pain of GI conditions, such as functional dyspepsia and gastroparesis. Next slide, please. These neuromodulation methods have also been studied in chronic pancreatitis. Here are 3 of the methods that have been previously studied in clinical trials. The first one at the left is traditional acupuncture, in which needles are used in acupoints of the body, And this is performed by trained personnel who knows the different acupoints of the body and applies specific pressures with these needles in those points. And in a clinical trial of 15 participants, this showed that there can be some short-term pain relief after treating patients with acupuncture. Now, additional research has been performed to discover, for example, if electroacupuncture, which is a modification of the traditional acupuncture technique, but instead of using pressure points, it uses electrical current into the needles. And this technology did not show in a clinical trial to be effective on reducing pain in chronic pancreatitis. Transcutaneous electrical nerve stimulation, or what is also called as a TENS unit, has been studied in one study of 16 patients. The difference of this with the other techniques is that instead of using needles, uses sticky pads similar to what is put in the chest when we do an EKG. And we transmit electrical current through these points that are connected to different nerves of the body that we want to stimulate. And it doesn't necessarily need a trained personnel for this. However, in a small study of 16 patients, this did not show to be effective. Next slide, please. Here in the University of Michigan, we have accumulated experience with the use of transcutaneous electrical acustimulation. This is a modification of the TENS unit that we reviewed before, but it doesn't work the same because instead of being applied with the electrodes in areas of the nerves, it's applied in acupoints, similar to what the acupuncture is. And this uses electrical current, similarly as a TENS unit, and can be self-administered at home, meaning participants can just use these areas of electrodes as shown in the images and apply in different parts of the body as recommended by the treating healthcare professional. And we are pioneering here in the University of Michigan using this for different gastrointestinal conditions. Next slide, please. So this is the device that produces the electrical current that then is connected to electrodes that are placed in the acupoints. This is the size of a watch, pretty much. It's small. It can be held in one hand, and it can be put in a holding clip. So you can put it in your belt, in your pants, and your commodity at home, and just connect this to the electrode leads that will then be put in areas of your skin, allowing to transmit the electrical energy with the goal of reducing pain. This is wireless. However, it requires charging, and it comes also with a charging cable and a USB power adapter. Next, please. So when this device has been investigated in different conditions, this has recently demonstrated to be effective in improving abdominal pain in patients with acute pancreatitis. So this was a clinical trial that was conducted between China and the United States. And in 42 patients who had acute pancreatitis and had abdominal pain, this device was given and to half of the participants, and the other half received what we call sham, or receiving the device in an area that is not supposed to work. And when they compare the pre-treatment pain scores with what the effect of the device was after 2 days of having used it, it clearly demonstrated that there was an improvement of pain as compared to using sham. And this was by using the device only 30 minutes, twice a day for 2 days. Next. When they look at the mechanisms of why is this happening, in this particular study, they find two main reasons why pain is reduced. Number one, that device reduced inflammatory markers that were measured in the blood. And by this, it seems that it mitigates inflammation, and by that, it can improve pain in patients with pancreatic disorders. And in addition to that, it was also noticed that it can increase vagal activity when they measure EKG, a special test during the hospital admission, and they were able to see that this vagal activity, which is pretty much connecting most of our GI tract with our brain, allows that communication and kind of help with the motility and symptoms of patients with acute pancreatitis. So this device has also been used in patients who have irritable bowel syndrome. And in this figure, you can see the results of a clinical trial of 52 patients in which patients received 4 weeks of treatment with the device, twice a day for 30 minutes each time. And as compared to receiving sham, which was receiving the stimulation in a different area of the body, there was clear demonstration that the TEA can improve abdominal pain and symptoms of irritable bowel syndrome. So based on this preliminary data, we were very excited to launch last year in October an open label feasibility trial. Our goal was to enroll 10 patients with chronic pancreatitis who had abdominal pain, and the goal was to provide 4 weeks of outpatient therapy with the TEA device, 30 minutes twice a day during this duration. And we're almost completed enrollment of this. We need 1 more participant, but what we learned is that this device is very feasible to offer to our patients. It's safe. There was no adverse event so far, and it seems to decrease pain in some patients with chronic pancreatitis. We're still awaiting the final results of this feasibility trial. However, this served to provide preliminary data to generate the next stage of what we want to learn with the device, which is to conduct a larger trial with more participants in which we want to explore if there's a benefit of using this device in terms of pain, and see if this can help more to patients who have either wiring or plumbing problems. This is some preliminary information about the trial. We plan to enroll 40 participants. Participants should be enrolled for about 3 months during the study. During this time, they will receive 4 weeks of treatment and 4 weeks with sham, meaning everyone who is enrolled in the trial will be able to receive treatment during the study, but at different points during the study time. And participants are required to complete the intervention and questionnaires that will be given. And since there's not a goal of obtain blood samples or require for the participant to be inside in the University of Michigan, all the intervention and measurements can be completed from home, and participants do not need to be in the state of Michigan to be part of this clinical trial. And any participant with chronic pancreatitis, adults who have abdominal pain more of 3 out of a scale of 0 to 10 over the past 3 months will be eligible to participate, even if they have been on opioids. Who is not eligible for this? Participants who are about to start endoscopic therapy or pancreatic surgery. We do not recommend starting the device because this may confound the results of our study. However, if participants have had this in the past and they did not get any better with these interventions, they are still eligible for the trial. If the participant had a recent event of acute pancreatitis within the last few weeks, they would not be eligible while the inflammation is improving. But after a month, the participants have resolved the pancreatitis. They can then be eligible to participate. And if they have suspected or diagnosed pancreatic cancer, they are not going to be eligible to participate in this study. My final remark is that we have learned from others that have conducted already clinical trials with this device that this is a very safe procedure, and it is considered by the FDA as a non-significant risk device because it's very similar to a TENS unit. The only kind of symptoms that participants may experience can be discomfort from the electrical stimulations. However, as you saw in the photo of the device, the current that is being administered can be modified by the participant, so it's not painful. The other problem can be sometimes a skin irritation or allergy in the area that the electrode is placed, but it can be placed in the opposite side, not necessarily in the same side if this occurs during the study. But more importantly, if effective in reducing pain in chronic pancreatitis, the TEA may be an alternative intervention with a better safety profile than other treatments that are currently available for treating pain in chronic pancreatitis. I want to thank my collaborators at the University of Michigan and in other institutions, including the University of Pittsburgh, where I train and with whom I continue collaborating strongly. And I want to thank my funded sources, especially the American College of Gastroenterology, who has already funded this phase 2 trial that I have shared with you today. And we plan to start enrollment of this by the fall of 2024. Thank you so much again for the invitation.
Thank you, Dr. Machicado, for discussing the TEA study and its potential benefits for the pancreatitis community. Your work offers a promising new home-based treatment approach for the pain management. We look forward to having the stage 2 TEA clinical trial on our website and sending the details out to our patient community in the coming weeks. For those wishing to enroll in the stage 2 clinical trial starting in the fall of 24, please contact the study coordinator listed on the slide. And if you have any questions for Dr. Machicado, please share them in the Q&A box. Quick and kind reminder, if everyone can type in their questions into the Q&A box, it'll help us streamline the questions and get through them really quickly. Thank you so much. Megan, if you could get to those questions and have them answered, that'd be great. Over to you.
Yes, great. Thank you to our speakers and to everybody for asking a lot of questions. Looks like we've answered, and Dr. Gittes has answered a number of them in writing, but I'm going to bring some of them up again because they've come up so many times. Dr. Gittes, when will the chemical pancreatectomy be ready for human trials?
Right. So there are two people asked that question, not surprisingly. So the large animal toxicology studies that we're going to be doing is scheduled for middle of August. The follow-up period that the FDA requested was 30 days. So we should have all the data together by the end of September. And then I anticipate we'll be going back and forth with the FDA. We've already done a pre-IND with the FDA. So we know what some of their thoughts are. I think, my guess is we'll go back and forth with the FDA for maybe 6 months. So I'm very optimistic we could be starting a clinical trial within a year from now. But the good thing is the FDA is required to respond to something we submit within 30 days. In fact, if they don't, that's actually like it's approved. So you kind of hope they don't respond. But but in general, it's a pretty quick process. And this therapy is going to be categorized what they call breakthrough therapy, because it's such a big problem, and this is such a different paradigm, different kind of, and there's not a good solution out there. So I think that helps expedite the process.
And thank you, Dr. Machicado. Your trial, is that currently recruiting?
Thank you. We have a feasibility trial that we're still about to complete. We have one more patient to complete, but then the phase 2 trial, that is the comparative efficacy trial that we want to see if there's an effect on pain response, will start recruiting by the fall. So there will be more information coming along, and I'll be happy to share that with Mission Cure to share with our patients.
Great. And that's kind of the different approach to this problem, which is there a simple device that you could put on for 30 minutes twice a day to relieve your pancreatitis pain? And that trial will be starting in the fall. Great. Is there any hope that both of these treatments will reach children?
Yes, I'll start. I think that from the perspective of helping with pain, this is actually a very good option that can help children because this would prevent giving any other more invasive treatments, and perhaps, helping them alleviate some of their pain even from home. So from the perspective of this, yes. However, the trials that we are starting to conduct are in adult patients. So, more research will be needed to demonstrate whether or not it's effective in children.
And Dr. Gittes, I know that there are a number of people on participating in this webinar who have children who they're thinking about TPIAT for. So when will that reach children?
I don't know, but I don't think it'll be very long because this is not like a trial where you have like different groups and you have to get statistics and all that. It's either going to work or it's not. And if it works, I think you're going to have really a hard time holding back the progression of the treatment to large populations. So once you're showing efficacy in adults, I can't imagine they're going to delay it in children very long. In order to have it be non-surgical, the child probably has to be 7 or 8 years old because of the anatomy. It's very difficult for the ERCP for them to get into just the pancreatic duct in a smaller child.
And that kind of relates to another question, which is at what stage of chronic pancreatitis would be ideal to intervene with chemical pancreatectomy?
Right. Well, this TPIAT thing is, a relatively early phase, and we're going to start with that. But I think if it's working in that, I don't think there's any limitation on who you would do it in. I think as long as there was not some severe ductal anatomy problem or something where you would not, or full of stones or something you couldn't get past. And I think it's one of these things where, it blossoms as you have motivated people who want to try it, and we'll learn as we go. In terms of somebody asked, people that have diabetes are typically not candidates for the TPIAT. But they would definitely be candidates for this. In fact, they're better candidates because I think it's going to make their beta cells work better, and I think by improving the milieu of the pancreas, getting rid of all the enzyme, all the toxicity, you may then allow the beta cells to regenerate and grow, which they're very capable of doing, but they probably can't do it very well in that environment.
Great. And I think there might be TPIAT experts in this webinar, and I'm not a doctor, but my understanding is for children, they are starting to do it at earlier stages, but for adults, it tends to be a fairly late stage intervention. But please, we'll correct that if that's wrong. Once you start the human trials, how long would it take to have it available to others? Does it have to go through a certain timeline? And I will ask that of both of our guests.
I'll start, I guess. I don't really know. I think it depends on how clearly effective it is. If it's anything like it is in the monkeys, and it's going to expand very quickly. I don't know. Our plan is to do what's called a pilot. So it's not a phase 1, it's a pilot, because it's so crazy what we're doing. It's not like we're just testing a drug or something. So a pilot is a very small number of people, but if we take 10 people with chronic pancreatitis that are going to get a TPIAT and they're all better, I don't know how you can, I don't know how you can prevent the floodgates from opening. I just can't imagine.
In terms of the TA device, we're gonna be on the kind of phase 2 trial. We need efficacy trials. I think on the pipeline is this demonstrates to be effective. It will be typically a 5-year process until we have like a strong data to demonstrate whether it's effective or not. We will learn also earlier if it's not, but I think that's kind of the timeline until we can understand better its effects on pain.
And would the chemical pancreatectomy apply to people with pancreas divisum?
Yeah, I just wrote a response to that. I said, yes, for sure.
One more quick one, Dr. Gittes, would you take candidates from the UK?
Absolutely. Yeah. We have a partner in Sweden who's can't wait to do this. He's Matthias Lohr, and so if it applies to Sweden, it applies to the UK for sure. We're going to start the trial here in Pittsburgh, but again, it goes back to that question about how fast will it spread, and I don't think it'll take very long to get to Europe and Asia.
Wonderful. All right. Well, thank you both very much for joining us today. And I am now going to turn it over to my colleague, Olivia, to close us out.
We post resources for our patient community as part of our patient education program. So please subscribe to our newsletter on our website and follow our social media handles to learn more. Our virtual door is always open, so if you have any questions or feedback, please let us know. Thank you again, everyone, and we hope you enjoy the rest of your day.